Take note in this case, the patient's unaffected arm supports the affected arm, reducing pain. Here, the physiological position of the bones of the shoulder joint are demonstrated using an anatomical inlay. Highlighted now are the head of the humerus, the acromion, the coracoid process, and the glenoid cavity of the scapula. An animation is used to show the anteriorly dislocated head of the humerus from different angles. Take note that the head of the humerus is trapped behind the glenoid cavity of the scapula. This is typically seen in an anterior dislocation. Therefore, during reduction, traction is placed on the arm in an anterior direction to reduce the head of the humerus. The prominent humeral head can be palpated anteriorly on physical examination. Also, the loss of deltoid contour can be seen under the acromion. Based on these clinical findings, an anterior shoulder dislocation can be diagnosed. It is advised to examine the neurovascular status of the upper limb before starting the reduction. Although most injuries are caused at the time of dislocation, some may occur during the reduction. Adequate analgesia should be administered and, if required, sedation. This should be done as per local pain management protocol before positioning the patient. The patient is placed in a supine position. This is done slowly and with care. The shoulder should be supported to reduce the pain as much as possible. Relaxation of the shoulder muscles is essential for a successful reduction. Analgesia and patient comfort are therefore essential. In this case, the table is lowered to flex the shoulder into 90 degrees of forward flexion. If the table cannot be lowered, the shoulder should be flexed manually by holding the arm in an upright direction. Both hands are positioned proximal to the wrist joint and traction is exerted by lifting the arm. Care should be taken to exert continuous traction. If this is not done, the patient's muscles may go into spasm. Note that the shoulder is being held up and is not touching the table. This way, the patient's body weight is used to effect reduction once the patient's muscles are relaxed. Anterior traction is exerted for several minutes by the physician. If shoulder reduction is not achieved this way, externally rotating the shoulder may aid reduction. The physician maintains his position and continues to exert traction. His left hand is now positioned distal to the elbow, and the arm is exo-rotated and some extra traction is exerted, as shown here. Here it is shown again slowly in one smooth movement. And again using an animation. Note that the head of the humerus is moved anteriorly, the arm is externally rotated, and the shoulder is reduced. A typical palpable and audible clunk can be felt and heard on reduction. With successful repositioning, the patient's pain is immediately reduced. The repositioned shoulder joint is positioned across the patient's body and should be supported while doing so. External rotation of the shoulder joint should be avoided, especially with the arm in 90 degrees of abduction. The patient is helped while the affected shoulder is supported by the physician. Physical examination is used to evaluate the procedure. In a successful reduction, the prominent head of the humerus is no longer palpable and the deltoid contour is restored. The stability and function is tested by the physician slightly flexing, extending, and abducting the patient's shoulder joint. A sling is used after the reduction to maintain the position of the arm. Take note that post-reduction care is as per local protocol. The angle of the elbow should be less than 90 degrees so the hand is positioned higher than the elbow, to prevent swelling of the forearm and hand. It is advised to repeat the neurovascular examination in order to make a comparison to the findings prior to the reduction. If a change is noted, it can be acted on. It is advised to perform imaging studies after the reduction. This is in order to evaluate the position of the humeral head and to detect any fractures.